Greetings, I'm Bruce Ovbiagele, the editor-in-chief of JAHA, and along with Pam Peterson, the deputy editor of JAHA, would like to welcome all of you to this inaugural special episode of our AHA with JAHA podcast, entitled Distinguished Hearts and Minds Roundtable. This annual forum will feature a conversation with American Heart Association distinguished scientists for that particular year. It's intended to highlight the work and perspectives of these brilliant laureates with the goal of informing and inspiring other scientists, strategists, and society about advances in cardiovascular science and the journey of these very successful academic role models. Over the course of this 90-minute podcast, we will get to know about what these eminent scientists have done, learn about what they have learned, and hear about how they see the future of research in their various fields. So they are Dr. Patrick Eleanor, who is the acting chief of cardiology and co-director of the Corrigan Moynihan Heart Center at Massachusetts General Hospital. He's the director of the Cardiovascular Disease Initiative at the Broad Institute and professor of medicine at Harvard Medical School. We also have Dr. Deepak Srivastava, who is the president of Gladstone Institutes, the Robert and Linda Maley Distinguished Professor, director of the Roddenberry Stem Cell Center. He's also professor of pediatrics, biochemistry, and biophysics at the University of California, San Francisco. Next, we have Dr. Carlos Ferrario, who is professor emeritus in the Department of Surgery at Wake Forest School of Medicine. We also have Dr. Jeffrey Weitz, who is professor of medicine, biochemistry, and biomedical sciences. He's also the Canada Research Chair in Thrombosis, endowed chair in cardiovascular medicine at McMaster University, as well as executive director of the Thrombosis and Atherosclerosis Research Institute. We also have Dr. Judith Hochman, who is the Senior Associate Dean for Clinical Sciences, Harold Snyder Family Professor, Associate Director of the Leon Charney Division of Cardiology, Co-Director of the Clinical and Translational Science Institute, and Director of the Cardiovascular Clinical Research Center, all at New York University. And last but by no means the least is Dr. Cornelia Wyand, who is Professor of Medicine and Immunology at the Mayo Clinic Alex School of Medicine, and also Professor of Medicine Emerita at Stanford University School of Medicine. She's the director of the Mayo Clinic Program in Immunity and Inflammation. So I'd like to extend our heartiest, no pun intended, congratulations to all the AHA 2023 distinguished scientists for this very well-deserved recognition. So I'd like to start off by asking each of our esteemed guests a general question. Over to you, Pam.
I just want to second the warm welcome. We're very pleased to have you here with us today. And if each of you could tell us, what does being named an AHA Distinguished Scientist mean to you? And we'll start with Dr. Eleanor.
Well, thank you, Pam and Bruce, for that warm welcome. It's a delight to be among such an esteemed set of colleagues as well. I'm deeply honored and flattered to be named a distinguished scientist. It's humbling, and it's really, in my mind, a reflection of the work of the talented students, fellows, postdocs that I've had the fortunate opportunity to mentor over the last 20 years. I think it's their hard work, tireless efforts, and really creativity and ingenuity that are captured in this award. So deeply grateful to all of their efforts. And to the AHA. It's a fabulous community. I've benefited from the collegiality, camaraderie, and funding from the American Heart Association over the years. So thank you.
Thank you. Dr. Srivastava?
Well, thank you, Pam and Bruce, for doing this. As a physician and a scientist, I think this recognition that means a tremendous amount to me, having devoted my life essentially to caring for children with heart disease and trying to find solutions, understanding the genetics of the disease and finding solutions for regenerative medicine. This recognition by one's peers is often the most remarkable one. And like Patrick, I think it represents the hard work and dedication of so many people in my laboratory over the last nearly 30 years. And in particular, many of them have gone on to do great things in their own laboratories. And I think this recognition, I hope, highlights not just the work that we've done in my lab, but also the work that spawned from that. And I'm also grateful to the Gladstone Institutes, where I've done much of the work over the last 18 years, for giving me the opportunity to do this. But at the end of the day, if we can make a difference in the lives of the patients we care for, then we'll have made a real impact, and that's what drives me. And the recognition is nice, but the real driver is that.
Dr. Ferrario.
Bueno, first I want to thank Dr. Ovbiagele for his kind efforts in putting on such an exciting program together. It is really an honor, and if I look back over my career, it was simply a work of love, and I'm very grateful to the American Heart Association. My career started as an American Heart investigator. I won't tell you how long ago, but it was many years ago. And my research and that of my colleagues was an accomplishment of them more than I. I was grateful to have had over 53 postdoctoral fellows in my professional career, and was able to publish significant work in understanding the regulatory mechanisms of the renin-angiotensin system. I'm very appreciative not only to the American Heart Association, but through my years at the Cleveland Clinic, where as the last disciple of Irving Page, he really was the one that formed my spirit and created the ethics for research that I tried to fulfill during these years.
Thank you. And Dr. White.
Yes, thank you. Like others, I'm humbled and honored by this award. This award is not for me, it's for all the undergraduate, graduate, and postgraduate learners that have been with me over a long period of time and have become independent investigators in their own right. And I'm particularly grateful for recognition by the American Heart Association, because I've been with this organization for a long time, starting as a postdoctoral fellow in New York City and moving on from there. And this is an organization that recognizes people in a number of different specialties. I'm a hematologist, not a cardiologist, not a cardiac surgeon, but a hematologist, but one who's interested in thrombosis, the underlying mechanism for many of the disease which we all study. And it's really an honor to receive this award from the American Heart Association and see that they look beyond the heart.
And Dr. Hoffman.
So I am also very deeply honored and humbled by this award. And it's special from the American Heart Association because of the incredible work they do across all domains. And also, as others have said, I got my first grant from the American Heart Association, and that led to preliminary data that allowed me to do the SHOCK trial, which was the trial that actually showed that emergency revascularization will reduce mortality in cardiogenic shock. And there's been no therapy for the last 25 years that has been proven beyond early revascularization to reduce mortality in cardiogenic shock. So the AHA got me started there. Doing clinical trials, which is what I evolved to do after being a bench scientist, really takes teamwork. So as others have said, this really reflects an enormous team both at my institution, NYU, and globally to have achieved these results in clinical trials that have actually changed AHA, ACC guidelines. And the last thing I want to say is that I'm especially touched and honored that clinical trialists are recognized as scientists. So there's a science to clinical trials. There's both the hypothesis you're testing, which is what scientists do, and there's also the methodology and design of clinical trials. That's a science as well. So I'm, once again, I'm deeply honored and greatly appreciate this support.
Thank you. And Dr. Wayand.
It is a very humbling experience to be part of this group of awardees. And I'm really here to say thank you to the American Heart and to the community of scientists that have driven the sciences in the cardiovascular diseases. I'm here to represent physician investigators that dare to stand in two fields, try to bridge these two fields to move the science forward. I'm a vascular immunologist, and my primary interest has always been how the immune system deviates from protection and causes tissue inflammation. And this process is, of course, relevant in many, if not to say in most, cardiovascular diseases. My clinical emphasis has been in treating patients that have inflammatory blood vessel disease, particularly vasculitis of the large arteries and the aorta. And my clinical training started in rheumatology. But over the years, I was adopted by cardiology because I had to acquire the expertise to manage patients that have this particular type of inflammatory blood vessel disease. No, I'm humbled by the fact that immunology is playing an increasing role in our understanding of diseases, not just the cardiovascular diseases. And it is gratifying to see, and history has shown that basic sciences can ultimately change our understanding and the management of disease. This journey is most gratifying, and receiving this recognition from my peers, I'm very thankful for it.
Thank you all, and I'm going to pass it over to Bruce for the next question.
No, thanks, Pam, and thanks to all of you, to our audience. As you can see, our distinguished scientists are as humble and collaborative as they are distinguished. And I piggyback on Jeffrey's comments. I'm a neurologist, so I'm grateful that the AHA looks beyond the heart. We're going to move to our specific questions for our esteemed guests. I'm going to start off with Patrick, if I may. Patrick, what are the implications of GWAS discoveries that you have made in atrial fibrillation on our mechanistic understanding of the disease and also on the potential clinical applications?
Great. Well, thanks, Bruce. Over the last 20 years, we've learned quite a bit about the genetics of atrial fibrillation. First, that there is a genetic cause or basis for atrial fibrillation, and that the genetics can serve as one of many risk factors for this common arrhythmia. In the last decade in particular, with genome-wide association studies or analyses of common genetic variants, we've established a very good genetic fingerprint of atrial fibrillation, at least in individuals of European ancestry. These days, there are more than 300 different genetic loci that have been identified for atrial fibrillation, in keeping with other common diseases such as myocardial infarction, hypertension, and diabetes. The real challenge now is really in two directions, in my mind. One is to broaden our understanding of the genetic basis of atrial fibrillation to other races and ethnicities. We still have a paucity of data in individuals of African descent, Southeast Asian, and Asian ancestry. We additionally need to then understand what is the mechanistic implications of this. We have this great fingerprint, but we now have more genetic loci than I could study in the rest of my career. So if there's a young postdoc out there and they want to try to beat up one of these genes at one of these genetic loci, you have plenty to choose from. And then finally, I think where we need to turn is as we unravel the molecular pathways, we increasingly need to turn to how to target those to develop new therapies for atrial fibrillation. Currently, our therapies are incredibly limited. The most common drugs that we have all have side effects and limited efficacy. And that's why clinically, there's such a common use of an invasive procedure with ablations. And while those ablations may be great for our support of our hospitals and our cardiology divisions, we have to imagine a future where there are better therapies at hand for such a common disease.
Thank you, Patrick. Over to you, Patrick.
So, Dr. Shrivastava, do you think induced pluripotent stem cells technology will replace current drug screening technology over the next decade?
I do think induced pluripotent stem cells will play a very important role in being able to refine both our drug discovery process to be most relevant to human disease, as well as refine our ability to predict toxicity and other adverse effects of any given drug. And I think a great example is an arc of discovery that we've engaged in my lab over the last actually 20 years now, that went from taking care of a patient with aortic valve disease, mapping the gene that caused this in 4 or 5 generations in this family, using induced pluripotent stem cells to understand mechanism of the disease, and then using those cells also upon which to do drug discovery. That effort has led to a drug now that works beautifully in mice, and we're now advancing towards a clinical trial. But it could never have been done without using human cells from patients with the disease, and that's really what enables is how IPS, or induced pluripotent stem cells, will enable such drug discovery. And then once we have a drug, if we're able to predict in a better way before taking those even into a clinical trial, whether they might have toxic effects in the heart particularly, but also in other areas, iPS cells offer the opportunity to have another screening step to de-risk a drug before going through a clinical trial and spending tens of millions of dollars and then finding out that it works great, but we can't give it to anybody because it has difficulties. So in that sense, I do think iPS cells will play a very important role in future drug discovery over the coming decade.
Fantastic. Thank you. Bruce.
Thanks, Pam. Thanks, Deepak. And so the next question is for Carlos. And so, Carlos, given that there are so many antihypertensive drugs available, why is research on hypertension still important? And how do you think the new aldosterone synthetase blockers will fare in the future?
Thank you, Bruce, and thank you, everybody. Well, clearly, the availability of antihypertensive drugs could stall the development of new approaches to the treatment of hypertension. On the other hand, treatment of hypertension and knowledge or research in hypertension is vital, not only because it optimizes treatment strategies, improves patient outcomes, reduces healthcare issues, and addresses the global impact of this condition. In addition, research in hypertension is leading to the development of new molecular approaches to the pathogenesis and the treatment of the disease. My laboratory was the first to identify, discover the existence of a counter-regulatory mechanism within the renin-angiotensin system that depended upon the generation of a peptide, angiotensin 127, which acting upon a receptor, the MAS receptor, block or neutralize the hypertensive and proliferative actions of angiotensin 2. My laboratory then, after identifying this pathway, discovered the importance of angiotensin converting enzyme 2, the homologue of ACE, because it had a critical role in the pathogenesis of cardiac hypertrophy and heart failure. Later on, our research with the action of angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers on ACE2 led to the importance of angiotensin converting enzyme 2 in the development of COVID-19 infection. So this is how our research has contributed to the investigation of mechanisms and the development of new strategies. Indeed, we are currently using molecular approaches, very novel use of monoclonal antibodies in the preclinical arena to treat hypertension. That, if successful, will radically change our approach to treatment of hypertension, because instead of having to administer or prescribe drugs for daily use for life, we, if lucky, may be able to administer these monoclonal antibodies maybe once every 3 months or longer. So it is very important that we continue research in hypertension, because it has opened new approaches and new treatments to the disease itself. And this is, in a sense, this research involves in understanding the interaction between the renin-angiotensin system and aldosterone. And aldosterone synthase is a new approach to the treatment of hypertension, particularly resistant hypertension, because it blocks the synthesis of aldosterone without causing the side effects associated with mineralocorticoid receptor antagonists such as eplerenone and others. So we think that these are important things. The limitation of this synthase, aldosterone synthase inhibitor, is that we still need larger, more robust clinical trials to understand the importance of this therapy in terms of preventing long-term clinical events, including the progression of chronic kidney disease.
No, thank you so much, Carlos, for that. So clearly a lot of work that still needs to be done, especially in terms of improving efficacy, in terms of the mode of delivery, and also in terms of addressing issues like treatment-resistant hypertension. Thank you. Over to you, Pam.
So Dr. Weitz, we'd like to hear from you about what you see as the unmet needs in anticoagulation therapy in our current era.
Yeah, thank you for that question, because we've seen tremendous progress in anticoagulant drug development over the last 10 to 15 years or so. But if we step back for a moment, the ultimate goal of anticoagulant therapy is to attenuate thrombosis without disrupting hemostasis, without causing bleeding. And I think the new generation of anticoagulants, the so-called direct oral anticoagulants like Eliquis and Xarelto, come closer to that goal than our previous agents, the vitamin K antagonists like warfarin. But we still have a ways to go. The annual rate of major bleeding with the direct oral anticoagulants in our elderly atrial fibrillation population is about 2 to 3% per year. And if you add up major and clinically relevant non-major bleeding, it's 10 to 12%. So we still have a ways to go with developing safer anticoagulants. And the problem is that bleeding, or the fear of bleeding, has led to the undertreatment of a lot of eligible patients with atrial fibrillation. Even the most recent registries suggest that at least 30% of our patients who should be getting anticoagulant thromboprophylaxis for atrial fibrillation, for stroke, they're not getting it. And when the direct oral anticoagulants are being prescribed, there's often the inappropriate prescription of the lower dose regimen with the false belief that that will reduce the risk of bleeding. And it doesn't reduce the risk of bleeding, and increases their risk of stroke. So we still have a ways to go. And I've learned recently about patient-important bleeding and how the bruising that patients get with anticoagulants and leads them to change their lifestyles, to wear long-sleeve clothes to disguise those bruises, and can lead them to skip doses or stop the drug. So we still have a long way to go to develop safer anticoagulants.
Thank you. Yes, it's been quite a path. So I will turn it back over to Bruce.
Thanks, Pam. Thanks, Jeffrey. The next question is for Judith. Judith, you're an eminent clinical trialist. I want to ask about a specific trial. How have the results of the ischemia trial influenced clinical care of ischemic heart disease patients?
We have to go back a few decades. I have been studying with a very large team of investigators what the role of revascularization is for the spectrum of patients with ischemic heart disease, from cardiogenic shock to stable ischemic heart disease. So in other words, the right procedure for the right patient at the right time. So there were two major landmark, very robust trials that asked the question, if you open a coronary blockage in someone with ischemic heart disease with either a stent or, in one of the studies, bypassing it, does that lead to fewer events, cardiovascular events, death, myocardial infarction? And surprisingly, the answer was no in those two studies. And that was we had cognitive dissonance, like how could that possibly be the case? So we designed the ischemia trial, and NHLBI funded it to address limitations in those excellently conducted trials, but there were limitations. And so we tested whether an invasive strategy, without knowing the anatomy up front, because that may bias who gets the procedure. We had a core lab know the anatomy, but didn't divulge it to the investigators or the patients or their clinicians. So the invasive strategy was compared to an initial conservative strategy. Both strategies got maximized medical therapy, but one of the strategies went to the cath lab, cardiac cath lab, and if the anatomy was suitable, they had stent or bypass surgery. What we saw was that there were early upfront risks, more myocardial infarctions with the procedure, but late benefits. So at 4 years, there was a reduction in myocardial infarction, especially due to spontaneous MI. Importantly, what the results showed, and we now have extended follow-up, addresses exactly what patients care about. What do patients care about? They care about living longer and feeling better. Out with extended follow-up to over 7-year median, we did not see a survival benefit with a routine invasive strategy. And we saw the quality of life was improved at a median of 3.2 years. So the bottom line is, the results of the ischemia trial mean we need shared decision-making with patients. They need to know the data. If you have angina, you will feel better, higher chance of being angina-free with an invasive strategy, but you're not going to live longer. You have an increased risk of procedural MI up front, but a lower risk of spontaneous MI during follow-up. And interestingly, what we know now, implementing that, patients have very different priorities. Some patients want an invasive procedure to get rid of this blockage, and some absolutely just want medical therapy unless they fail medical therapy. And so we've rolled out the ischemiariskcalculator.org, where the patient and you can actually plug in how much angina they have, and they can see what the chance that they're going to feel better with invasive versus a conservative strategy up front. One of the very practical implications in terms of change of practice was we presented right before the COVID pandemic. And there have been publications since saying, wow, the ischemia trial was so reassuring that we didn't have to rush patients who had moderate or severe ischemia on a treadmill, which is the entry criteria, to the cath lab, because cath labs were closed for elective procedures. And it reassured clinicians and their patients that they could wait or defer the invasive procedure.
Well, that's fantastic, Judith. A very timely trial and clearly prefers the patient and is done in partnership with the provider. Thank you for that.
Thank you. So Dr. Wyans, next question is for you. Given the recent approval of colchicine to prevent myocardial infarction events, do you think clinicians will routinely use this medication in the ischemic coronary artery disease population? Definitely something comes up with me on rounds with residents and fellows all the time. And if not, why do you think that might be the case?
Well, it does show that an old dog can still learn new tricks. Colchicine is just the beginning in a new category of immunotherapeutics in cardiology. And as you know, we have used it for decades to manage gout. We have good understanding of what it can do, and we have good understanding of its toxicity. In the clinical trials in cardiology, it has shown reduction in primary and secondary endpoints, but there has also been a signal in infection risk. And that exemplifies that immunotherapy has to find that very fine balance between treating just enough without losing the protective side of the immune system that protects us from infection and that protects us from cancers. Colchicine on a mechanistic level, its mechanism of action focuses on the microtubular system. So it really interferes with very basic cellular function like phagocytosis, like migration, like activating the inflammasome, like cell division. And we give it with the intention to really interfere with myeloid cells crawling out of the blood into the tissue to cause inflammation. But as you hear from its mechanism of action, it's pretty nonspecific. So I think what will happen that we will get much smarter of which cell types we have to target, which pathways we have to target to safely inhibit inflammation. Colchicine is the first step into the right direction.
Fascinating. And yes, hopefully we can teach old docs new tricks. Bruce, I'll turn it back over to you.
Thank you, Pamela. Thank you, Cornelia. So we're now going to ask another general question of each of our esteemed guests. And the question is, what are the major opportunities facing your own area of research today? And we'll start off with Cornelia again, and you alluded to the issue of colchicine and its promising pipeline of subsequent agents. But what are the opportunities, Cornelia, in your neck of the woods?
What's the new frontier? The new frontier will be to understand how the aging process affects the risk for inflammation. So advancing age is the single most important risk factor for cardiovascular disease, but not only for cardiovascular disease. It comes as a package. It's also the single most important risk factor for neurodegenerative disease, for the risk for dying from infection, as we have seen during COVID. Right? It was really age is the predisposing factor of severe and fatal disease. What we the common denominator of the morbidities that are associated with advancing age is actually the fact that the immune system ages. And we know that when the immune system ages, we lose immune competence, we lose immune protection. Counterintuitively, the aging immune system also gains function. And that gain of function lies in its propensity to become inflammatory. And the field has named this concept inflammaging. The aging host develops inflammaging. So if we want to understand why patients get inflammatory disease, how they become susceptible to cardiovascular disease, we need to understand why and how the immune system gets old. And this question will lead us to take the heart to the bone marrow, the hematopoietic stem cell that over lifetime acquires mutations. And as we know, there is an important component of clonal hematopoiesis contributing to inflammatory risk. The question will lead us to understand how bone marrow-derived macrophages and tissue-resident macrophages deal with tissue destruction and damage, how they heal. So, you know, the healing process is equally affected by this immune aging phenotype. And the question will lead us into the lymph nodes, to the adaptive immune system. How can it learn? How can it memorize? How can it forget? Because there are times when we want it to forget. So the root of cardiovascular inflammation lies in the bone marrow and in the lymph nodes. And once we understand how lymphoid tissues change with age, that holds the great promise that we get to the root of inflammation and of most, if not to say many, cardiovascular diseases, neurodegenerative diseases, risk for cancer, risk for infection. So all of these morbidities of the second half of life, you know, their secret lies in how we can actually keep the immune system young and functional.
Judith, what are the major opportunities facing your area of research today?
So there are many opportunities. Cardiogenic shock is an area that I've been interested in since the 1990s, when we did the shock trial with many, many partners. After we showed that early revascularization saved lives in cardiogenic shock, complicated acute myocardial infarction, in the almost 3 decades since, no other therapy has proven to reduce mortality. And it's humbling and kind of, I would say, depressing, dismaying. We need better therapies. We need more clinical trials, and we need answers as to how to reduce the mortality rate of cardiogenic shock patients who, if they undergo early revascularization, which does save lives, still have about a 40 to 50% 30-day mortality rate. The other major opportunity for stable ischemic heart disease is implementation science. We found that in the ischemia clinical trial, we had recommendations for lifestyle changes and medication use that are proven to improve outcomes. And we started off with about 20% of patients at baseline adhering to what we considered sort of optimal medical therapy light. They weren't smoking, they were taking aspirin, they were taking statins. And by the end of the trial, that doubled, which is fantastic, but it was only 40%. So we really need to figure out how to get patients to make lifestyle changes and take their medications to reduce their risk of events.
No, thank you, Julia. The real-world implications are extremely important. Jeffrey, what looks intriguing in your field?
Well, I guess starting with what Cornelia just said, why is it so important to get at the root cause of inflammation is inflammation and coagulation are intimately linked. So wherever there's inflammation, there's also activation of coagulation. So understanding inflammation will help us to better target coagulation and vice versa. Coagulation can lead to inflammation and create a vicious circle. So it is really important to get at a better understanding of inflammation, and in so doing, we'll get a better understanding of coagulation. I think over the last 20 years or so, we've gained a remarkable insight into the molecular pathways of blood coagulation, and we've now identified pretty much all of the potential targets for new anticoagulant drugs. And right now there's a lot of attention on factor 11 inhibitors as a new class of agents to attenuate thrombosis, and perhaps factor 12 inhibitors as well. But on the other side of the coin, if we want to decrease thrombosis, there's two ways to doing that. One is to suppress coagulation with anticoagulants, but the other way is to enhance fibrinolysis or clot breakdown. And of course, in your area in stroke, we use fibrinolytic agents as clot busters, or we do thrombectomy, and in the heart we also get rid of those clots. But there are other ways that we can enhance endogenous fibrinolysis by inhibiting some of the inhibitors. And we're just starting now. We've got really interesting preclinical data with some of these novel inhibitors of fibrinolysis, and we're just starting a proof of concept in humans to determine whether we can enhance endogenous fibrinolysis and cause clots to regress without having to give a thrombolytic agent like TPA or tenecteplase. And by so doing, we may also be able to attenuate inflammation and keep that process suppressed.
Thank you, Jeffrey. Very exciting and very much welcome. Thank you. Carlos, what are the bright and promising spots in hypertension?
Well, that's a very, very important question. And there is controversy. The dictum today is that what is important is to lower the blood pressure. And it really does not matter how the blood pressure is lowered, provided that we get 130 over 80 millimeters of mercury. What that type of thinking leads to is to not to realize that even in those patients whose blood pressure would be defined as control, the residual risk of cardiovascular events exceeds by 2 to 3-fold the actual reduction in risk attained with current medications. Even though cardiologists have fully bought the idea of residual risk, a new immunotherapy has been created to counteract the residual risk, hypertensinologists continue to dismiss it in its entirety. We are among the few who have been publishing data analysis of currently accomplished clinical trials, demonstrating that residual risk is greater than 70%. That does not mean that these drugs are not effective. What it means is that the benefit achieved, including ACE inhibitors and angiotensin receptor blocker, affects or improves a small segment of the population. It is unfortunate that clinicians continue to be remiss in understanding this problem, because this is not only an issue of therapy, it is an issue of research in developing new drugs. So I think that the American Heart Association, our leading lab organization, needs to take a very forward step in understanding the limitations of our current antihypertensive medication and the importance of developing new approaches to the treatment of hypertension so that patients will benefit directly.
No, thank you, Carlos. So well said. A lot of food for thought there. Thank you. Deepak, what are the avenues of optimism in your area?
Well, I'm extremely excited about the future, because we finally have a number of the key tools and technologies we need to go to the next step in understanding human disease. And when I think about it, it involves in part convergence of three major technologies, one being the genomics and artificial intelligence that can be applied to those large data sets of genomes, use of stem cells that we can make from patients, and being able to edit the genome in a precise manner. And the reason I'm excited is that the combination of that was going to allow us, and is starting to allow us, to understand genetic variants at scale. But then when you understand the genetic variants associated with disease, the major question comes, in which cell are those mutations relevant? And the advent of single-cell biology is now allowing us to say it's not just affecting this organ, it's affecting this subset of cells among hundreds of others in this organ. And once you can narrow that down and model that in stem cells, you can then think about ways to drug that specific target. So now you know what to go after. And then the advances also related to AI with AlphaFold and being able to predict protein shapes and the impact of mutations on that protein shape and the drugs that could then correct the impact of that mutation, finally opens up the opportunity to do very directed, not just understanding of disease mechanism, but now also drug development. And as we do that, now we have CRISPR tools to edit the genome, correct mutations, really make sure that those are the relevant genes in disease, and ultimately maybe even treat patients with CRISPR-directed therapies to just correct mutations rather than having to accept it and then drug it. So those technologies now can be brought together to really both understand and treat disease in ways we couldn't before. And then as well, I'm also excited about the fact that now we can understand cell fate decisions well enough that we can induce cells to be almost whatever we want. And one of those examples is work that we had led some years ago that's now being carried forward into a clinical trial by Tenaya Therapeutics, which is to take the scar-forming cells in the heart and direct them to become new beating cardiomyocytes right where they are. So not having to take cells out, transplant them back in, but convert the resident cells into new muscle to regenerate from within. And that technology is also moving forward. So I think, to wrap it all together, it's the ability to understand our cells well enough to control them at our will to address human disease that I think is the big opportunity in really all fields, but certainly the heart field has been leading in that space.
Well, thank you, Deepak. Your excitement is infectious. Thank you for that. Patrick, what do you find tantalizing in your area?
Well, I think, thanks, Bruce. I think not just in my area, but just globally in cardiovascular research, the two areas that have really looking intriguing at the moment are, we're really at the infancy of applying artificial intelligence and specifically generative AI models to answer either biologic questions or to help us refine and our understanding of and process clinical data at scale. So I think both of those applications, I think as Deepak alluded to, with AlphaFold, you've got a great initial signal from our understanding of protein folding. But if you then play that out across all of the genetic, transcriptional, single-cell data sets that we have, you can really see very, very broad applications. And then the same in the clinical realm, as we increasingly apply machine learning methods to look at the prediction of latent diseases. So we've seen this for atrial fibrillation and the ability to predict this off of an EKG for individuals at high risk years in advance, or subtle findings on an echo that can be portend a future risk of dilated cardiomyopathy. We're really in the early days, but it's going to be very, very exciting in the years to come. And I think the other big area has to be in the range of therapeutics. I think we've moved from small molecules are still a core foundation, but just think about it. In the last decade, biologics have become routine in clinical care. And that's already having an amazing impact. And now we're moving to peptides, siRNAs, CRISPR-based editing. We really have a huge toolbox that we can come at any individual disease with. So I think, as Deepak was saying, the intersection of our increasing understanding of the molecular mechanisms, it's now less about, I think now if you have a gene you want to target, there are multiple methods to do that. And if the gene's causative in a given disease, we have a whole array of potential therapies that we can target that gene with. So it should be quite exciting in the next 10 or 20 years.
No, thank you for that, Patrick. And certainly it sounds like lots of increasing tools in our therapeutic armamentarium. So thank you for that. Over to you, Pam.
Well, thank you to all of you for updates in your relative fields. It's very exciting. You're all very clearly, obviously, distinguished in your fields, but it's really fascinating to hear about what you see coming on the horizon. So I really appreciate that. A lot of food for all of us to think about. So Dr. Eleanor, just to continue on what you were talking about, what do you see as barriers to widespread clinical application of polygenic risk scores for cardiovascular disease in individual patients?
Well, thanks, Pam. Just as a reminder, a polygenic risk score is the cumulative effect of the contribution of many genetic variants to a common disease. So if we take atrial fibrillation as an example, I mentioned earlier that there were about 300 genetic loci for AFib. For any given genetic loci, you'll have 300 risk variants from mom and 300 from dad. So a total, if you're at the highest risk, you'll have all 600 genetic variants that confer a risk of AFib. And on the other end, you'll have 0 or no risk. Though most people, because these are normally distributed in the population, most people will be right at 300, and it'll be a bell-shaped curve. What we know is that if you stratify the upper or lower fraction of that polygenic risk, you have an increased risk of disease that in some cases is very marked. If you take the highest 4 or 5% of many common diseases, of that polygenic risk, that will equate to an equivalent of the monogenic risk for many of these same diseases. That was work led by Amit Kara a number of years ago. It's important to realize, though, that polygenic risk, it's best to think of it as just another biomarker, the same way that we would use as age, gender, or anything else as a biomarker. And the contribution to a disease is going to be based on the heritability of that disease. So if you have a highly heritable trait, like height, or say aortic disease that Deepak studies, then the polygenic risk will have a big influence. On the other hand, if you have a trait that has a very low risk or very low heritability, it may not contribute much. So to get back to your question, with that background in mind, where do I see us headed? I think you can imagine a couple of scenarios, to put it in more practical terms. You could imagine folks that are at, say, an intermediate risk of ASCVD, and you're not sure whether they should be on a statin. if someone had a very high genetic risk, despite being an intermediate clinical risk, you could imagine that they would be a candidate for a therapy. And there have been a number of studies that have looked at this to date. In the setting of AFib, you could also envision that if you're one of the 1/3 of patients that come in with a cryptogenic stroke, and we know that anticoagulants haven't been effective in this population, but if you were at the 97th or 98th percentile of polygenic risk for AFib, you may want to consider more extensive or invasive monitoring. But overall, the key thing that we're going to need are, just like any other biomarker or therapy, we're going to need prospective randomized clinical trials to really show us the effectiveness of any polygenic risk deployed in a clinical setting beyond our current management strategies.
Again, more food for thought, things to think about. I don't want to know if I have all of those risk factors. I'm going to turn it back over to Bruce.
Thanks, Pam, and thanks, Patrick, and thank you for the pragmatic recommendations pending definitive clinical trials. Thank you for that. Next question's for Deepak. Deepak, do you see a role for computational modeling, machine learning, and multi-omics in developing a phenotype of systemic chronic inflammation?
Yeah, I think, again, this is another opportunity to bring technologies together, including looking at single cells, transcriptome, as well as epigenetic status, and incorporating that with machine learning approaches to understand basis of disease. And our lab had done something like that in the heart, recognizing that while we're trying to regenerate muscle to address heart failure, we also recognize that another component of heart failure is in fact activation of fibroblast within the heart that then somehow affect the muscle cells and further decrease cardiac function. And so even if you can't create new muscle, if you can address the fibrosis and the inflammatory component related to those fibroblasts, then you might be able to improve cardiac function. And in fact, through a number of single-cell multi-omics studies, what we found in the last couple of years is that, in fact, the heart senses stress somehow through immune cells in the heart that then send a signal to the fibroblasts to tell them to get activated and start laying down more collagen. And that results in the fibrotic tissue and in signals we haven't yet understood, somehow affecting the actual contractility of the muscle. So what's clear is that the inflammatory state of the body and the organ can adversely affect organ function. And we have the tools now to dissect that through combination of generation of large single-cell data sets and machine learning to interpret patterns in those that then could be altered. And so that's now led us to new drug targets to actually alter this dysregulated state of both the macrophages or immune cells in the heart as well as the fibroblast. And so it's opened up a whole new doors of study and targets to address heart failure that actually don't affect the amount of muscle you have, but still can affect organ function in a favorable way.
Very interesting. Thank you, Deepak. Over to you, Pat.
Thank you. Dr. Ferrario, a very broad question that I'm sure we could spend a very long time on, but what do you see as the current challenges to reducing disparities and improving blood pressure control and preventing cardiovascular disease?
There are two factors, or two components to that answer. The first is the fact that we have still failed to address appropriate control of blood pressure in minority population, particularly in our case, the Hispanic Americans and the Afro-American population. The RESTORE program that has been recently advanced, Health Equity Research Network for the Prevention of Hypertension, is really a very positive step forward by the American Heart Association, because for the first time takes all of these very separate components of factors that contribute to minority disease together and attempt to see how effectively we can reduce them. So this program is really one important component. The other thing that I want to address, and I think it has been said by all of these distinguished participants, is that hypertension or cardiovascular disease in general, we should view it as a disease of regulation, like Page first established. Hypertension in particular is associated, or is believed to be the result of the activation of mechanisms that produce vascular disease, vascular hypertrophy, cardiac hypertrophy, inflammation. I do not subscribe to that idea. Hypertension is not a result of agonistic expression of biomarkers. It is the result of an inability of the counter-regulatory mechanism to restore homeostasis. In that sense, within the renin-angiotensin system, the failure of the counter-regulatory axis that we now describe as angiotensin converting enzyme 2, angiotensin 127, and the MAS receptor, leads to a stage in which pro-inflammatory mechanisms are free to cause disease. And so we need to now pay more attention to the possibility that hypertension is an expression of a disease in which counter-regulatory mechanisms fail to neutralize the positive agonistic effects of other agents. And so I think that one thing that should be hopefully developing very rapidly is the generation of new drugs or new compounds or new methods by which we can re-energize, reactivate the compensatory mechanism.
Thanks, Carlos. And I have to associate myself with Carlos's remarks about the Restore Hypertension Network, which is looking at addressing social determinants of poor control of hypertension amongst minorities. And I'll also put in a shameless plug that we are working with the investigators of the Restore Network to put together a special edition, a spotlight issue in JAHA in the next several months. So look out for that. But thank you for indulging me.
Yeah.
Next question is...
For a second, I think that is...
Of course, please.
Something that maybe needs to be even reconsidered. When I first moved to Wake Forest from the Cleveland Clinic, I was startled at the severity of hypertension present in the population, and we were the first to actually document that there was excess cardiovascular death within the southeastern United States, those 13. And one element that I still, as a clinician, I always recall is that hypertensive patients in the South look older than those elsewhere. And indeed, we have many, many cases of individuals that are really looking aged and they are hypertensive. So related to what Patrick was saying, there are some things that need to be explored genetically in terms of this aging process, accelerated aging process associated with the South.
No, it's a great point, and I agree with that. Having spent 6 years in South Carolina myself, I do recognize and agree that seemingly the burden is much greater there and deserves much more investigation. Thank you. Next question is for Jeffrey. Jeffrey, you are a giant in thrombosis research, and so my question for you is, to your mind, what is the future of factor 11 inhibitors?
Well, that's a great question. Obviously, there's a lot of excitement in this area. I can think of 8 randomized clinical trials that are going on, phase 3 trials now with factor 11 inhibitors. that will enroll over the next 3 years or so 78,000 patients. So a tremendous effort. And like Patrick was saying, the armamentarium of agents is impressive. We have in those trials, we've got 2 small molecule inhibitors of factor 11A, the activated form of factor 11. We have an antibody that binds to factor 11 and locks it in the unactivated conformation so that it can't be activated. And also in the package, we have antisense oligonucleotides that can reduce the synthesis of factor 11. We have antibodies that block factor 11A activity. So we really have a number of tools to tackle factor 11. How they will all shake out, I don't know. The hope here is that because factor 11 appears to be essential for thrombosis, for clots to grow inside a blood vessel and to block blood flow, activation of factor 11 by thrombin and amplification of the clotting system seems to be an essential pathway. In contrast, for hemostasis, for plugging holes in blood vessels and forming the hemostatic plugs that stop bleeding, the activation of factor 11 by thrombin is mostly dispensable. So we have that potential to reach that holy grail of attenuating thrombosis with little effect on hemostasis. And now with all these different agents available, we can not only determine the role of factor 11, but also determine how best to tackle it. Is it best to reduce the levels of factor 11? Is it best to block its activation? Best to block its activity? We will be able to find that out with these different agents. And recently, as there was a press release from one of the factor 11 companies that a phase 2 trial comparing this antibody that blocks factor 11 activation with Xarelto in patients with atrial fibrillation, underpowered for efficacy, but on the safety side, a very highly significant reduction in both major bleeding and the composite of major and clinically relevant non-major bleeding with the antibody compared with Xarelto, which is one of our go-to agents for stroke prevention and atrial fibrillation. So it speaks to the promise, and that dose of this antibody was shown in a previous trial we did in patients undergoing knee replacement surgery to be more effective than Lovenox and enoxaparin at preventing post-operative venous thromboembolism. So it clearly has potent antithrombotic activity, and now we have safety data. So I'm hoping that we can realize that promise with these agents and over the next few years identify the best strategies to target factor 11.
Thank you, Jeffrey. It sounds like cause for cautious optimism, so thank you.
Her next question is for Dr. Hochman. What lessons from the conduct of the ischemia trial could inform the design of future trials in the treatment of ischemic heart disease patients? I know you've talked a little bit about designing clinical trials, so insights into this would be helpful.
So I think we need answers much more quickly. We need to enroll much more quickly. So what that means is, ideally, every clinician in clinical practice should be part of a clinical trial. So a patient presents with, let's stick to cardiology for now. Patient presents to a cardiologist's office with cardiovascular disease. The physician should be able to easily see what trial this patient might be eligible for. If there's equipoise, if it's unclear what the best management for the patient is. I mean, a lot of them you're going to see it's very routine. But for many, we are always trying to make advances in improving their outcomes, and there should be an easy way for you to participate. See which trial that patient is eligible for, enroll them, and have them as part of the trial. in that regard, we need equipoise. It's very hard to enroll in some of these trials. The ischemia trial is very difficult to enroll in because physicians are biased. They think they know the answer. They think that patients, and it's logical, with moderate to severe ischemia on a stress test, need revascularization very quickly. On the other hand, we had the results of COURAGE and Barry 2D, those landmark trials I referred to earlier, that actually showed outcomes weren't improved. It was very hard for physicians to accept those trial results and allow their patients to be enrolled. I suggest every physician read Daniel Kahneman's book, Thinking Fast and Thinking Slow, about our biases and how we need to think more slowly and thoughtfully with our cortex instead of our forebrain when it comes to these decisions. The other lesson for the clinical trial designs in the future is, and we learned this from COVID, is that a platform trial where there are multiple therapies to test in the same population, a platform trial where you can have different arms, different treatments, and you can be eligible for one treatment or two or three or potentially four, is a very efficient way to study a particular condition. And in addition, instead of the typical frequentist, that we call frequentist statistical analysis, we need to use Bayesian analysis more. We all know that it's not logical if a trial ends and the p-value is 0.049, that we say that's a positive trial, that therapy worked, and if it's 0.051, it didn't work. That's nonsense. The Bayesian analysis says using the study data and doing hundreds of thousands of simulations, what is the post-study probability that that treatment, whatever intervention you were testing, actually makes a difference by 1 percentage point, by 2, by 3 percentage point, or by 10% reduction, 20% reduction, 30% reduction. And the clinician will make the decision. A 90% probability is good enough for me. Or maybe an 85% probability is good enough for me because that's a very safe therapy. It's very cheap. And so it's a very logical way to have an analytic plan. You can also reach decisions in interim monitoring about futility more quickly than you can with a frequentist analytic plan.
The last specific question for our eminent panel is for Dr. Wyand. And so, Cornelia, you spoke earlier about teaching a old dog new tricks. Are there any other promising immune modulating drugs in the research pipeline for ischemic coronary artery disease patients?
So, of course, there are the cytokines, and the playground for the cytokines, of course, has been autoimmune disease. We know how to use anti-cytokine therapy. We know how to use it organ-specific, organ non-specific. We know how to dose them. We know what their side effects are. I think that the management of cardiovascular disease will enormously benefit from that. And they will come into cardiology to treat ischemic heart disease, to treat stroke, to treat cardiomyopathies. Recent work has emphasized the important and possibly causative role of bone marrow-derived macrophages in atrial fibrillation. So this leads to the question, can we actually do cell-based therapy and control the number and the activity of such macrophages, and can that be a therapeutic modality to actually prevent and treat atrial fib? We will see considerable cross-fertilization. From oncoimmunology, we will see considerable cross-fertilization from the side of the autoimmune diseases. There are now discussions whether actually CAR T cells are a potential curative intervention in lupus. So this is an enormous step forward, and immediately raise the question, can we actually really profoundly affect inflammatory disease with cell-based therapy? So that's what's immediately in the pipeline.
That's great. No, thank you so much, Cornelia, for that. And so we're now going to move to the next general question. And I should just say that up until now, we've been informed and inspired by the profound knowledge of our eminent scientists. With this last question, we hope to glean some wisdom. Over to you, Pam.
I will second what Bruce has said. I've learned a lot in this conversation today. You all kind of opened up a little bit with some insights, I think, into this question, but we'd like to hear more about, a key segment of our audience is really the early career stage. And so we'd like to hear what your wisdom is about the best career advice you've ever received, as well as what your approach is to mentoring and developing the junior colleagues and junior people that you work with. And we'll start with Dr. Shrivastava.
For my own career, mentors have played an instrumental role clearly in my success, and I've tried to pay that forward with trying to do the same with my mentees. So I'd say that one of the best bit of advice that I got as I was growing up and training was to pick a problem that you're interested in for the long haul and try to keep penetrating deeper and deeper into that problem. And as you're doing that, look for observations that might even be impactful for other fields, because as you go deeper into any disease process or cell type, invariably you might stumble across more general concepts that apply to all cells. And as you're doing that, make sure that you're in it for the long haul, and that takes persistence and passion to solve a problem. So that was some of the best advice that I received, and I've tried to do in my own career as I've gone along. Now, in terms of my mentoring style, whether it's a graduate student getting their PhD degree or a postdoctoral fellow, they're often with me for 4, sometimes 5 years. And that is I see it that they're putting a tremendous amount of trust in me to nurture their career during that period. And so I try to both train them scientifically, but also make sure that we develop a deep enough relationship over those 4 or 5 years that can last a lifetime. And I tell my trainees that at the end of that, ideally, if we've done it right, after their parents, I should know their strengths, weaknesses, vulnerabilities, probably better than anybody, but it takes time to do that. So I try to do that. I try to be their coach, their cheerleader, which is maybe my biggest role, and impart some degree of wisdom through my experience as they face obstacles in their own scientific life as well as personal and otherwise life. So I take it as an all-in approach to mentoring for science and for life, and it's been one of the most pleasurable aspects of my career, certainly over the last several decades.
That's fantastic. Thanks for sharing. Dr. Eleanor, what are your thoughts?
Well, thanks, Pam. And I would echo a lot of what Deepak said. I think mentoring is the most enjoyable part of what I do on a day-by-day basis. If I take myself back, 20 or plus years at this point, I guess it would 4 or 5 things come to mind. The persistence is one. Sometimes this is a battle of attrition. Unlike Dr. Hochman, my first grant was not from the AHA, and I've certainly received AHA grants later. My first AHA grant was scored at the 76th percentile, where 1 is good. The same exact grant was funded later at the NIH. This is fickle, some of these grants. I have grants rejected all the time. That's just part of the business that we're in. And so don't get too dejected by any paper or any grant. It's very, very hard when you spend years on it not to take it personally, but try to be objective about it. I think also, like Deepak, it's important to tackle a broad question and to have something with a runway that you can be studying for years. In my case, I started with AFib, and there's plenty to do there for years and years to come. I think also when you start, you need to keep a laser focus on one area and not skip around to too many different things, and try to focus on answering a long-term question and not get distracted by techniques, because new methods, new techniques will come and go, and make sure you're using those techniques to answer the question rather than just playing with the techniques themselves. I think the other is we're really in our infancy of understanding a lot of cardiovascular diseases. I think when you finish your training, you're at the snapshot in time where you think all of the problems have been solved. We know the coagulation pathway in Jeffrey's case, but when you look at the new therapies that have come along just for factor 11, it's incredible in just the past year or two. So the world's not solved, and there are plenty of opportunities to go with. And then I guess, lastly, don't be boring. It's very, very easy to be incremental and do the next experiment. But I think you need to constantly ask yourself, where are you going to go in 2, 3, 5 years? And try to get there, and not make sure that you're not just doing the next experiment because it's the easiest thing, but you're pushing to get to somewhere further along the line. So I think those are a few take-home lessons I try to impart with anyone that's new in the lab.
Judith, what's the best career advice you have received? And what is your approach to mentoring and developing junior colleagues?
So I had, a wonderful mentor, Bernadine Healy, who is an extraordinary woman. I want you all to Google and look her up and look at her career. And I've had the good fortune to mentor many people who are now very successful division chiefs, leaders in various places. So the idea about, first of all, you have to pick the right mentor. It has to be a good fit. And then you need a contract. You need to agree on what your goals and each of your responsibilities are up front. You need to have regular sessions and come prepared to those sessions. The mentor needs to give feedback and the mentee needs to give feedback. The mentor is there to provide support. Now, it might just be a career mentor. It might be a scientific mentor, or it might be a combination. And I've done both. If it's a scientific mentor, you should be meeting every week. If it's a career mentor, it might be twice a year. Sometimes it's only once a year to make decisions about the career path. The mentor should help you network professionally. If they need a mediator because they're reaching some obstacles in terms of perhaps collaboration, there are very strict rules for collaboration where you set the rules of the road up front. You should teach them those rules because everything is team science now. The mentee must know the rules of collaboration. If you go to the NIH website and look at teamwork or collaboration, you will see a set of very clear checklists of what to do up front. And the other message is to get a niche, something that you are expert in that you can contribute to the team, because so much of what we do in investigation, even basic research, is teamwork. So you want to bring some expertise, some niche to that team. So build an area, preferably that's underserved, where not a million other people at your stage are studying it, so that you could bring that expertise to the team.
Thank you, Judith, for the great background and profound insights. Over to you, Pam.
Dr. Ferraria, what are your thoughts?
Well, a lot has been said. In my personal experience, the first recommendation is choose your mentor very carefully. Because as Dr. Deepak mentioned, you're making a lifetime commitment to your mentor. I was very fortunate to have trained with one Nobel Prize, Bernardo Usai in Argentina, with Irving Page, and they really marked the rest of my life. So choosing your mentor is very critical. The second thing that I really believe is believe in yourself. Don't be afraid to fail, because for every failure in research, there is a new opportunity. There is a new discovery. And so I always encourage my postdoctoral fellows and graduate students to actually look at the failure as opening a new avenue, a new discovery. And the third thing, which I recently subscribed to by a Nobel Prize that gave a lecture at the council meeting, change your subject every 10 years. Don't stick on one thing all the time. I have done that in my career, and I don't know whether it's true or not, but it was successful to me, and it seems to have been very successful for a Nobel Prize.
Great thoughts, good advice, something to really think about. Dr. Weitz, what are your thoughts?
Well, not to repeat anything that's already been said, I think the best lessons I learned from mentors, and it is really important to pick your mentors carefully. The best lesson was tackle an important problem. It's much easier to start with a clinical problem and then go back to the bench and take a reductionist approach to understanding that problem, and then maybe take it through to animal models before taking it back to humans. Get the best training you can. Don't be in a rush to get through your training and get to that first academic job, because once that academic clock starts ticking, you're under the gun. So take your time, get the training. You don't have to learn every single technique, because techniques change and you can learn that, but get an understanding of how to address important problems and how to work your way through it. And as Carlos said, I think one of the most important things to learn is that you learn from your failures. There is an opportunity there to determine why things didn't work, and often the most interesting things come out of that.
Thank you, Dr. Weitz. Dr. Weiland.
Well, there's really not much to add. I think I wish I had been here before I ever started this journey to become an investigator and receive all of this really thought through advice. I have had the privilege, and it's probably the greatest achievement that we have, to help these young people to find their way. It's our most important job we have, and our most rewarding, I have to say. I've mentored over 100 students, residents, and fellows, and I have mentored individuals coming out of very different fields, out of anesthesiology, hematology, oncology, pain medicine, rheumatology, and of course, cardiology. And I have learned that their challenges are very similar. The first advice that I give a trainee is to choose a big problem. Don't really get stuck on a small problem. You want to be passionate. You want your work to have impact for those around you, and choose a big problem. The second advice that I give them is to say, okay, you need to learn clinical medicine. Just as you have to learn clinical medicine, you have to learn to be an investigator. You have to learn the tools to be an investigator. And the biggest steps in medicine have been made. They have come from basic sciences, right? We learned from the physicists what magnetic resonance is, and we're only able to image because they told us how this works. And without molecular biologists, we wouldn't even know there's DNA. How could we sequence it if we didn't even know there is DNA? And they had to tell us there is RNA, right, and what it can do. And they had to tell us which cells are there and which organelles these cells have. So I say to my trainees, look, you can't be a neurovascular surgeon tomorrow morning. You have to learn that. And the same holds for investigation. You have to learn the tools, understand them, and then you can know how to choose and apply them. My final advice is, say, you've got to be prepared for the unexpected. You have to treasure serendipity, and you never know where that next breakthrough is coming from. Most of the breakthroughs that have driven science have come from places where we never expected them. So we have to be open for that. And, science is not really a linear process. It's everything else than predictable. And to embrace that unpredictability, I think, is an important element that we have to teach them. And then finally, I advise them to solve the problem of aging, because that's the biggest problem we have as a society. And it will help us to understand inflammation. It will help us to understand the cardiovascular system and to bring the heart to the bone marrow and to the lymph node. So that's my advice that I give my young trainees.
Thank you so much, Cornelia. Thank you all so much for speaking about the words of advice you've received throughout your career, as well as your approach to mentoring and your wise wisdom. I think that is incredibly valuable for our audience that is at an early career stage and really looking to move forward. Bruce, I'll give you an opportunity to say any last words you have, and then I can close up.
I'm happy to close. I just want to say a big thank you. That was wonderful wisdom that was shared. Indeed, we have scientific sages, and I was inspired and reminded of things that I wish I had known previously. So thank you for that. I will, if I may, conclude this wonderful event by congratulating once again all of our AHA 2023 distinguished scientists on receiving this immense honor, and to thank them for taking the time and trouble to share their profound insights and experience with us. To our esteemed audience, if you've enjoyed this conversation, then please subscribe to AHA with JAHA podcast and look out for our next episode, which is being developed right now. And if you're not already following us on social media, you can find us on X, formerly known as Twitter, at JAHA _AHA, as well as on Facebook and LinkedIn as JAHA, Journal of the American Heart Association. Thank you all very much for kindly tuning in. Thank you.